really excited to be here. And just so that I can kind of get a lay of the land of who is in the audience, does everybody work for the same health system, the Christus Health System? Yes? Anybody not work for that system? No? Couple people? Okay. Are you guys in the area of Texas? Okay. And then how many people work at primary stroke centers or acute stroke ready hospitals? Okay. A few. What about thrombectomy capable? Comprehensive? A few. Okay. All right. And then nurses. Okay. Rehab services. Okay. Pharmacist. Saw a few pharmacists, yep. Physicians, APPs, nurse practitioners, PAs. A couple in the back. Dr. Welch, thank you. Okay, so, oh, do I have a clicker? Is it? Second shelf? This thing? Okay, excellent. Okay, so I do have a few disclosures. As she mentioned, I am a reviewer for the Joint Commission, so no one throw fruit or whatever you have left in your basket, because I am that person. But I do have to say that anything that we talk about today is not the opinions of the Joint Commission, right? But I can talk about some of my experiences. I am a consultant for Viz AI. We were, I think, the first hospital in the United States to use Viz AI. Anyone using AI software like Rapid or Viz? Okay, excellent. And then, as she mentioned, we have our own research company from where I work in Chattanooga. So really, my objectives and what I would like to discuss during our 30 minutes is not necessarily to give you all the answers, but to hopefully have you leave this session with a few questions. Right? Because I think that Dr. Welch set the stage this morning by saying, you know, oh, like mechanical thrombectomy came along and then that's kind of the only focus in stroke. That's only about 10 to 15% of patients, right? So what are we doing with the rest of patients? And then what is, now that we have the possibility of thrombectomy and we know that that works, that doesn't mean that everyone has access to it, right? So what are kind of some of the steps that we need to take? We're not done, right? So there's a lot more things that we need to do as it relates to stroke. So we did mention AI software, so not just having the images in your hand, and for those of you who are not familiar with Viz or Rapid AI, it is basically an app on your phone, and images are put onto your phone, but the AI software can detect bleeds, aneurysms, large vessel occlusions, subdural hematomas, those types of things. And I think the beauty of that is around communication. Right? Communication is the biggest key in organizing stroke care and stroke delivery. So if you have the ability, and when we first started using, and I've used both Viz and Rapid, but when we first started using this type of software, before that, right, if I had a patient that I was seeing in the emergency department that I thought had a mechanical thrombectomy, and this is back in 2014, 2015, when we were still doing Swift Prime and Escape, and we're taking patients for thrombectomy, I would have to call my interventional person, right, who he's very outdoorsy. Most of the time he was out riding his bike. And it was like, oh, I've got to go home. So his wife would come and pick him up, and she would take him home, and he would get on the computer, and he would look at the screen, right? So moving forward, we've now changed that he can be anywhere, and on his phone, he can pull up images, see the occlusion, activate the team, and everything moves a lot faster, right? But it's not just in like those types of platforms. There are other things that are coming out now to serve as methods for communication, and also some platforms where it's taking all the information that's in patients' charts, whether it's in their primary stroke, their primary care setting, their previous hospitalizations. It's summarizing all of that data and then providing a note or like a high-level summary to the provider who's seeing that patient in the emergency department. So using AI technologies to kind of scale through lots and lots of different data inputs to be able to deliver care in a really succinct and accurate way, I think is really great. So that would be more in the emergency department. And then apps for pre-hospital providers that are allowing us to triage patients a little bit better and then be able to have the teams that need to be in the emergency department waiting for them when they come in. And I also think that's really important for your underserved and more, I say urban, like non-urban, because I can't say rural. I have a really hard time with that word. So you'll hear me say non-urban. All right, and then how many people are using Connect-to-Place now? Okay, people still using Altaplace? Okay, so there's a few. All right, so providing Connect-to-Place to our patients now that it is FDA approved, and it's simpler administration. It's just a bolus dose. You don't have to do the drip that EMS providers, if they're going from a primary stroke center then to the comprehensive stroke center. I've seen a lot of hospitals that keep the patient in the primary stroke center until the drip is finished. So if the patient has if they're using Altaplace, so if they have a large vessel occlusion, then we're delaying transfer, right? So using Connect-to-Place will help with that. And I don't think that on my slides I put in there pre-hospital use of Connect-to-Place. What I meant by that was not giving it in the field without a CT, but two things. We have mobile stroke units that have increased the administration earlier in some places. I know Texas was one of the first places to ever have a mobile stroke unit with, I think, James Grotta, and he's at Houston. Is he with you? Oh, he's in Houston. Okay, all right. So I think that's great, and if you look at the best MSU study, it showed that there was an increase in providing patients Connect-to-Place like 33% faster, right? But what I mean by implementing EMS protocols is there are some areas of the country that EMS providers are not allowed to stop at a primary or acute stroke ready hospital and have to go to the comprehensive stroke center. And some of that has to do with the process, right? If we are able to give Connect-to-Place and you have a process in your primary or acute stroke ready hospital that would allow for really fast times, okay, and I see a lot of hospitals that are still struggling to get IV thrombolytics in less than 60 minutes, okay. American Heart Association is kind of pushing us towards 45, right? If you're meeting 45 minutes consistently, then maybe your internal goal should be 30 minutes, right? Now, I don't want us to confuse speed with safety, right? First, we have to be safe, and then we have to deliver care, appropriate care to the patient as fast as possible, because we know that if we provide these types of therapies sooner, patients have better outcomes, right? So what does the process look like? And then how can we expand treatment eligibility? So anybody have a wake-up protocol in your hospital? And people have wake-up protocols. Few people, okay. Or what about extended windows? Or using CT perfusion? Okay, couple. All right. So the DAWN and Diffuse 3 trials gave us the ability to provide mechanical thrombectomy up to 24 hours. Now that is not to say, oh, your left side is not working, you've got 23 hours to get to the hospital, right? But we still see patients who delay in their presentation. But use of wake-up protocols where patients are getting CT, CTA, and if they are not normally in the window for IV thrombolytics because they went to bed and they were fine, and then they wake up the next morning with symptoms, right? So typically that exceeds 4.5 hours. So if the patients present to the hospital within 4 hours, they do the CT, CTA, and if there's no large vessel occlusion, no bleed, then they go for an MRI where they get just a limited sequence MRI and look for DWI and flare mismatch. And then they would be eligible for IV thrombolytics if it's within 4.5 hours. Right? So that's the wake-up protocol. But then I see some organizations doing an extended protocol where they're really looking at imaging, because our imaging has improved over the years, and looking at the perfusion mismatch on CT perfusion to administer IV thrombolytics. And then optimizing your protocols for stroke. So recently the Zodiac trial came out, and what we saw is that for patients who are going for mechanical thrombectomy, it's important to lay their head flat. I think traditionally we've kept patients with neurologic diseases at like 30 degrees. And then from a primary or acute stroke ready hospital, if you have a patient who's transferring to a comprehensive stroke center, then what we're seeing is that patients are now being laid flat, provided that there's not a concern for respiratory issues or aspiration. However, in the Zodiac trial, at 24-hour mark, 86% of patients had an improvement in their NIH, and they did not have any patients that had aspiration pneumonia. So I think we still need to look at a few things surrounding that, but I think how impactful things that you're doing on a daily basis would be for our patients and for their outcomes. So, talking to a lot of primary stroke centers and acute stroke ready hospitals, they're like, well, what can we do? We're a primary center. We don't have all of this technologies. We don't have these huge teams, but that's truly not the case. Something just as simple as putting their head down and putting their head flat helps to improve their outcomes. And so that goes into these comprehensive stroke teams. And when I say comprehensive stroke teams, I don't necessarily mean at a comprehensive stroke center, but who's involved in planning your stroke protocols and implementing the care that you're giving. Even if you're at an acute stroke ready hospital or a primary stroke center, each person has a role, and I think that we don't do a really good job of assigning roles within our stroke teams. Trauma does this very different, right? Everybody has a role. Everyone knows what their role is. And if, from American Heart Association, stroke is part of ACLS, right? We talk about closed loop communication and leader roles, and everybody kind of defines their roles among ACLS. So are we doing the same thing with our stroke teams? And that includes everyone that touches the patient, early recognition, so whoever you have in your triage area for patients who walk in, how are you educating them and including them on their part of the team, including your CT techs. Sometimes they're just doing CTs, right? They just do the CTs, but they have no idea how impactful their role can be, especially in timing, okay? When I work with centers that are still struggling to get door to needle times, I really encourage them to look at their process from door to CT and then CT to drug given, and where are their barriers, right? Because if they're using telemedicine, like doing CT and then taking the patient back out to see the specialist in the room can cause some pretty significant delays. So it's all about looking at your process. And so I think that, developing this team and having everyone at the table, looking at it piece by piece, can be really instrumental in delivering high quality care. With ICH guidelines, I see a lot of organizations right now that are moving towards a code ICH, right? traditionally, nurse-led activations and maybe telemedicine or a neurologist in CT. Maybe you have a large team where it's residents and nurse practitioners and physicians, but as soon as they see a bleed is on the CT, if neurology is not the primary team taking care of that, everybody goes, oh, it's a bleed. And then they walk out, right? And then the ER doc and the nurse in the emergency department are like, where'd y'all go? Like, what happened? What are we doing, right? So really kind of focusing, and it never fails when I go to a primary stroke center. I say, yeah, so what's your plan for your bleeds? Oh, we don't take care of those, right? We transfer those, right? I hear that really often, but the fact is you do take care of them. You take care of them until you transfer them, right? And so oftentimes, patients that have hemorrhages, they don't always present with our BFAST positive exams, right? It's a headache, it's nausea, vomiting, those types of things. So how are we prioritizing their CTs? And then who's the team that's involved once we identify that a CT is done? So we have basically an hour to get our blood pressure under control, and then any reversal agents. And as Tracy told us earlier, you know, there are some reversal agents that may take an hour to get prepared, right? So really, what does the care of that patient look like? And so some of the new guidelines that came out, the code ICH, and then the spontaneous hemorrhage guidelines that came out in 22 can give you some direction for those. Identifying barriers to timely door in, door out times. So as Jennifer mentioned, this was the focus of my dissertation, and done a lot of work in the field of just stroke systems of care. First started with focus groups in the primary and acute stroke ready hospitals to talk to the stroke coordinators and stroke teams about what their perceived barriers were, and took their feedback, organized it into themes, things that were identified as barriers within the primary stroke system, primary stroke center, things like stroke-resistant attitudes, maybe not knowing what imaging to order or how to use the imaging once it's completed. There was a lot of back and forth, like they would just take the patient to CT, get a CT scan, go back to the room, wait for telemedicine to come on, then order a CTA, so they would have to go back to the department. If you want to, that is not on the list of how to win friends and influence people for your CT techs, to go back and forth multiple times. But stroke is a vascular disease, so getting a CTA for those, most of the time it's appropriate based on the symptoms that the patient came in with. And then really, how to utilize telemedicine if you have access to that. And I think that's a beautiful thing. If we have to look at some of the highlights out of COVID, right? I think that the use of telemedicine really kind of skyrocketed after COVID. And so we have a lot of specialists that are able to participate in patients who arrive at a primary stroke center. Then we looked at transport-related factors, of course, weather, right? Weather's always a factor when it comes to transport, but really not enough trucks that are in circulation, and so you're just waiting, and you just feel helpless because you're just waiting and waiting for someone to come and pick up this patient and take them somewhere. So kind of what is the solution for that? Are we gonna, does the comprehensive center own that? Is it a third-party ambulance? But the bigger question that I have, and some of the results that will be hopefully published in a couple of months from my second study, is when are we actually calling for EMS to come? Right? Are we waiting until the decision is made, or do we have some type of trigger based on like a scale that would say, hey, we are not going to keep this patient at this facility? If you're a primary or acute stroke ready hospital that does not keep bleeds, and you identify a bleed on your CT scan, what I saw in my qualitative stuff, which I'm going to be published later, but what I saw is that there were huge delays just in contacting EMS to come and pick them up, right? And if you know at 11 minutes that you're not going to keep this patient because that's when your CT is done, then why does it take you another hour to call CT or call EMS, right? And then we may not like to think of it, but those of us at comprehensive stroke centers may be part of the problem, right? And maybe some complex communication. How many people does your ED physician have to call before they get acceptance? We are overcrowded. You hear all the time, oh, we don't have a bed. They haven't been in bunk beds yet. So like where are we going to put them? And do you have some type of pathway that prioritizes the patient? Because they're also not going to go directly to their bed, right? They're most of the time, if they're being transferred with a large vessel occlusion, then they're going to go for the procedure and then go in. So what would that look like? Those are some of the thoughts that I have around that, but I think that it's important for us to all kind of recognize the role that we play in those barriers. And one of the things that I encourage systems to look at is people don't like to do these like stroke mock alerts or mock stroke alerts, excuse me, because they're like, you kind of roll your eyes. But what about like mock stroke transfers? Just to like have some awareness on what that process looks like. Once everybody leaves CT, what's the next step to getting the patient out the door? And so then when we look at emerging things that are coming down the pike, there's a lot of studies right now that, and I hope that you guys can see that. It looks really, really soft from here. But some new medications, the Lamostra trial, where it is a neuroprotectant and an IV thrombolytic that would extend the treatment window up to 24 hours. So can you imagine having 24 hours to give a drug and it would have the same or similar effects to what we use as tenecteplase right now? And then another medication, it's a DM199 that promotes bradykinin 2 into the area of the penumbra to basically kind of promote vasodilatation for collateral flow. And that could be for someone who is not a tenecteplase responder and or maybe is not eligible for tenecteplase can get those. There's some work with stem cell therapy and vagal nerve stimulation for upper extremity hemiparesis that is FDA approved, that is showing promise in patients who have lasting effects after stroke. There is something about spider venom. Now, many, many years ago, they did something with bat spit that did not prove to be beneficial, but spider venom, I haven't really looked into it because I don't like spiders. But I hear that there's some places in Canada, Australia, that are looking at some type of neuroprotectant that comes out of spider venom. And then really if you're looking at the brain-machine interfaces, something like Neuralink. Have you guys heard of that? I had the opportunity to meet the first kid that had Neuralink placed a couple of months ago. It's implanted into his brain. He's a quadriplegic. He dove and had a cervical fracture, and he's quadriplegic basically from the neck down. He's in a chair, but he's using this. All he talked to us about was how he was playing video games. So he thinks about it and it happens. Okay, and I kind of admittedly, like I'd heard about this and I was kind of like, wait a minute, what? After listening to him talk, I was like, wow, this is amazing. And there are other things that they're looking at. There's a company that's using something called Precision, where it's like, it looks like a Band-Aid basically, and they put it on the motor strip, and so the patient just has to think about it. Right? So there are going to be things coming. And, along the lines, like clinical trials are so important. We just had at ISC that the MEVO trials, so the middle vessel occlusions, were not as positive as we had hoped. And so more work that needs to come from those. So really, again, giving you some things just to think about within your program on how do you reduce your door in, door out times? How do you reduce your door to needle times? I feel like there's always room for improvement. And I encourage everyone in this room that you are working with these patients, you're working in your teams. You don't have to have a physician or have MD after your name to do research, to do quality improvement projects, and to present that data at other places. Each one of you are working with teams. You're working together to try to improve your process. And you probably do it after the Joint Commission leaves and leaves you with a party favor, which is an RFI or a finding. And they say, hey, this needs some work. So embrace that within your team. Figure out how you at your hospital are going to reduce your door to needle times or your door in, door out times, and then write about it. Publish it at different conferences. We're looking at ways to increase care in rural hospitals. I said it, rural. I'm very passionate about every patient who trusts us to take care of them. They show up at our door, and we can't say, well, we're not a comprehensive stroke center, you should have gone there. Right? We have a responsibility to those patients to give them standard of care while they're in our care and get them to the next level of care if that's what they deserve or what they require. Right? Everybody deserves the next level of care. But ultimately, working with these things, we will improve functional independence after stroke. Even those patients who do not get IV thrombolytics or who do not qualify for mechanical thrombectomy, our rehab services are so important. They don't need to see me anymore, right? They need to see a therapist so that they can function better. So really just simulation training. What are the next steps? How do you become active in your team to adopt some of these emerging therapies? And it can be led by anybody that's in this room. Okay. And that's my cell phone number and my email address. So if you have any questions, I'm happy to take questions now, but you can also email me or text me. I'll be on a plane in a couple hours, but I'll answer it once I get done. So any questions? Yes, they're going to bring, would you please bring her the microphone? Thank you. I don't think it's on. Is it on? Okay.
So I'm a newer stroke coordinator to our facility, and we've recently have changed our what we call our code stroke policy when a patient comes in. Through our emergency room, we have now switched to doing a level 1 versus a level 2. So level 1 is going to be your TNK candidates that are going to be, possible for that. And we've changed our process now where we no longer get the CT and the CTA at the same time. So this is new to us. We are definitely shooting for that 45-minute TNK administration goal, and this is, with this new process, we have achieved it, so it seems to have worked. But in your experience, does it work better for the patient and the flow long-term to go ahead and get both while you're there in the CT suite? Or do we historically think that this is a better way just to go ahead and get the dry CT and then return the patient back? Because we do have telemedicine. We do not have neurology on site.
Excellent question. And I will, in my experience, and I recently, so I was at Erlanger for 10 years, which is a large comprehensive stroke center. We saw 2,500 strokes a year. Changed and went 1.4 miles down the street to a primary stroke center, where that's where I'm purely administration or administrative, but that hospital, which was a primary stroke center, never met IV thrombolytic times in less than 60 minutes. Not once, okay? And I went there in November of 2020, and December 1st of 2020, we changed our process to a nurse-driven protocol, and everything happened in CT. Okay, so if you're gonna do, and which I'm fine with that. If you want to do a level 1, level 2, based on TNK eligibility, that's totally fine. I encourage you to give drug in CT. That's best practice. Because you wouldn't, and I think of it this way, if it's a vascular disease and you're not getting oxygen and glucose to your brain tissue, think about it from a cardiac standpoint, because everybody understands cardiac. Would you not give CPR to someone who needed CPR? And that's a little extreme, okay. But it's like if you're gonna, reperfuse the area, then giving them the drug is to do that. And now that you have tenecteplase, that makes it so much easier. So in order to change that protocol, and let me tell you, I've won a lot of friends in that month, but we had to put an Omnicell or a Pyxis in CT. So we had drug there. We have a pharmacist that came. That also wasn't popular because the pharmacists were like, we're busy, we're way down here, right? But they've embraced it, and now they are huge members of our team. And we don't have a pharmacist 24/7, and we use telemedicine. So telemedicine is in CT with us as well. Okay, so we go ahead, we activate telemedicine at the same time that we call the code stroke. And so as soon as they get on screen, they can start to, we may already have the dry scan by the time that they get on screen, but we allow them to see them in telemedicine while the team is working, getting the other things ready. And then as soon as they say yes, then we give drug. So sometimes that is before the CTA, sometimes it's after. But we go ahead and continue with the second scan.
But you're flowing less than 30 minutes from the time you're hitting the door to the time we're on the CT scanner and having neuro on camera.
Yes, and I can tell you, yes. And so going from a program that never gave IV thrombolytics in less than 60 minutes, like 4.5 years ago, we now give IV thrombolytics less than 30 minutes, 92% of the time. So it's doable, promise. Yes, ma'am. Okay. Any other questions? Okay. Thank you.
It's on now. I'm so sorry. I didn't mean to yell at you.
That's okay.
We have a question. I'm sorry. Awesome.
Yes,
Righto, Rachel, I just wanted to add, for years I've been on the state board, the Office of Acquired Brain Injury for the state of Texas. And anyway, you're talking about protocol and timing, perceived barriers, and so forth. We always had a tough time trying to get data and number from all the different regions and working with the legislature to give them that. From your aspect, your perspective, and what you bring to the table, what are some considerations, some things to consider, think about, ideas that might bring in more accurate data and numbers that would be to the benefit of the stroke or brain injury of any kind?
Yeah, excellent question. Most of you guys probably participate with Get With Guidelines, right? Yeah. I found that data is not always very accurate, right? And so we base a lot of our decisions based off of that. With our EMRs, we've gone to our providers, which we have nurse practitioners 24/7 that cover our stroke team. They are the ones who are collecting most of the data. So we've created a template in their note, and they put all the dates and times in. And then we have that pulled from Epic and downloaded into like our Power BI system that we use for kind of slicing our data. So it's all collected real time. And then I do have data abstractors and 3 stroke coordinators that, work to validate that data. And then we kind of analyze it as a team. But you do have to have something more real time and not, and by no means is this meant to say anything about the data, whoever's putting that data into Get With the Guidelines. It's usually like a quality person or a stroke coordinator that's having to upload all that data. If we're not clear in our note, and there's so much of this stuff that happens that's not actually documented, then whoever's abstracting that data is, well, this is probably what happened. This is probably what they meant. I think that this is what happened. And so it's really not clear. So just having those in whatever system you have, having a templated note, which those help us and they hurt us, right? But those time metrics at the top are what our nurse practitioners fill out every time. And so I feel like it's more accurate than just trying to pull it from different places in the medical record.